Hello, viewers, and welcome to the Tracking and Measuring the Opioid Epidemic as a Prevention Tool webinar series. This series is brought to you by the collaborative effort between the North Carolina Division of Public Health Injury and Violence Prevention Branch and the UNC Injury Prevention Research Center, IPRIC, and as an extension of this summer's North Carolina Overdose Summit, and specifically the Opioid Prescription and Drug Abuse Advisory Council, OPDAC, data and surveillance and research teams. And of course, many others have contributed to much of this work as well. I'm Scott Proescholdbell, an epidemiologist at the Division of Public Health with Injury and Violence Prevention Branch. I'm the Principal Investigator of the North Carolina Violent Death Reporting System and North Carolina's Prescription Drug Overdose Project and the new Enhanced State Opioid Overdose Surveillance, or ESOOS grant, which is just getting started, but will hopefully help with more timely and quality data for fatal and non-fatal overdose cases in the future. I'm moderating today's session and presenting a brief update on today's webinar. The webinar, again, comes kind of as a direct result of the North Carolina Overdose Summit that happened in June of 2017 as a follow-up to the data session. In that session, we had many partners, but we didn't have a lot of time, so this was the best thing we thought in terms of being able to share additional data. Because it had so many great experts on it with very little time, we decided that we would host a series of webinars so that partners could have extended time so they could provide additional details around their data source or data system. Today, we're pleased to have Sherani Jagroep presenting. Sherani was hired at the beginning of the year to be the Public Health Data Analyst for the HIDTA Heroin Response Strategy, embedded at the Division of Public Health. This is a public health and public safety collaboration funded by DEA and CDC through the White House's Office of National Drug Control Policy, ONDCP. She will talk about HIDTA and North Carolina's efforts to date. I'll follow this with an update on the overdose data and the North Carolina Opioid Action Plan and its data metrics. Today's webinar will be about an hour long. We'll have about 5 minutes between each of the presentations to answer questions. We encourage viewers to submit questions as they come up in the Q&A box, which can generally be found at either the top or the bottom of your screen, depending on how you've set it up, or the chat box, which again can also be posted there. Phone lines will not be open for audio questions. We also encourage you to chat among each other and contribute to the conversation with the chat box. This is the third of a series of data webinars scheduled to occur the third Thursday of each month from noon to 1 Eastern Standard Time in 2017. To find out more information about our presenters or future webinar topics, please visit the website. I think we'll post that up in the chat box. Again, we'll be recording and archiving this webinar. Check the inbox later for an email with a link. Past presentations should also be available at the webinar or the website that's listed. Now, let's turn it over to the first presenter, Sherani. Why don't you go ahead and take it away?
So quick, got it. Thank you, Scott. My name is Sherani Jagroep. I'm the North Carolina HIDTA Public Health Analyst. I'm based with the Injury and Violence Prevention Branch here at the Division of Public Health, and I'll be providing an introduction of the High Intensity Drug Trafficking Areas HIDTA program, as well as the Heroin Response Strategy. A quick overview of the topics I will cover in this presentation. First, what is HIDTA? How is North Carolina involved in HIDTA? What is the Heroin Response Strategy? The role of the HIDTA Public Health Analyst, current reports, and a little about HIDTA web app called OD Maps for overdose incident surveillance. The High Intensity Drug Trafficking Areas HIDTA program was created by Congress with the Anti-Drug Abuse Act of 1988. It is a federal grant program administered by the Office of the National Drug Control and Policy. The goal of this program is to reduce drug trafficking and production in the United States. This is done by providing assistance to federal, state, local, and tribal law enforcement agencies operating in areas determined to be critical drug trafficking regions in the United States. There are currently 28 HIDTA regions, which include approximately 18% of all counties in the United States, and a little over 65% of the US population. HIDTA designated counties are located in 49 states, as well as Puerto Rico, the US Virgin Islands, DC, and the Warm Springs Indian Reservation in Oregon. The HIDTA program currently funds 752 initiatives throughout the nation. Some of the activities of these initiatives include multi-agency drug trafficking investigations, intelligence and information sharing, and a few drug use prevention and drug treatment initiatives. There are 15 HIDTA counties split between 4 initiatives in North Carolina: the Triangle, Triad, Piedmont, and Asheville initiatives. These initiatives have central law enforcement agencies that receive resources from HIDTA for drug trafficking, for targeting drug trafficking. These initiatives are routinely coordinated with the DEA. In August of 2015, the Office of National Drug Control and Policy announced a public health, public safety partnership among regional HIDTA programs to address the heroin threat facing those communities. One of the goals of this strategy is to coordinate data sharing between public health, law enforcement, and others to respond quickly and effectively to overdose incidents and trends. The heroin response strategy now covers 20 states in 8 HIDTAs. North Carolina is part of the Atlanta Carolinas HIDTA, which also includes South Carolina and Georgia. To facilitate the public health and public safety partnerships, part of the heroin response strategy was to hire a public health analyst and a drug intelligence officer for each of the 20 states. Our roles are to work collaboratively to advance efforts in surveillance, treatment and prevention, and to develop sustainable relationships with law enforcement agencies, public health agencies, and community groups. The role of the HIDTA Public Health Analyst, which is me, is to develop reports containing actionable intelligence, to develop protocols for collecting and disseminating opioid-related data, to promote evidence-based responses to reduce overdose fatalities, and to promote evidence-based treatment for substance use disorder and drug use. In North Carolina, we have access to emergency department overdose incidents through the North Carolina Disease Event Tracking and Epidemiological Collection Tool, NC Detect. This data source allows us to track overdose incidents close to real time, although there could be a few weeks of delay for data entry to be final. I've been developing monthly opioid overdose surveillance reports using this ED data source as a starting point to start to inform law enforcement. But I've also been disseminating these reports to our public health partners. The reports show month-to-month trends in opioid-related overdoses with a breakdown of incidents that were specifically related to heroin. And it compares current incidents to last year, as well as our year-to-date total compared to previous years. The second page of the report highlights counties experiencing high rates of overdoses with a top 10 for the month listed on the right. Counties with less than 10 cases are suppressed. We also show opioid-related overdoses disproportionately affecting white individuals and those ages 25 to 34. Law enforcement and public health partners have provided positive feedback to these reports, which led me to also disseminate county-specific monthly reports. These are sent out to counties that I recognize are experiencing high rates of overdoses or a significant change in overdoses compared to their previous month. This example is for Rowan County, which started to see a significant change in the last 3 months. An extension of this monthly report includes 2 heat maps of opioid overdose ED visits and heroin overdose ED visits. Here you see the August heroin ED visit heat map, highlighting the total for August this year versus last year, and the counties experiencing the highest counts of heroin overdoses, as well as the gender, race, and age breakdown. That was an overview of part of my reporting efforts and sharing with law enforcement. Now I'm going to talk about an overdose detection mapping application program called ODMAP This is a free web app software developed by the Washington-Baltimore HIDTA program. It allows for real-time overdose surveillance. How it works is a first responder, such as EMS, fire, or law enforcement, who are at scene of a suspected overdose, would open up the web app and then record whether they were at a fatal or non-fatal incident, if naloxone was administered, and if they required a single or multiple doses of naloxone. These incidents are then geocoded to an approximate location and captures no identifying personal information. My HIDTA drug intelligence colleague and I have been introducing the software to several counties in our state to assess the utility of implementing it in North Carolina. The potential benefit is that it would allow surveillance of overdose activity across jurisdictions, and it would provide spike alerts to public health and safety to mobilize response efforts. A level 2 user, usually an analyst, would have access to the map of incidents. Here is a screenshot of the test environment. Here you can view incidents by date, like the last 7 days, by type of overdose, fatal or non-fatal, and you can search by a specific location. The potential for this software is in receiving real-time spike alerts. Counties are first evaluated at a baseline for what would constitute a spike. And when a spike is seen within a 25-hour period, an alert would be sent out to the level 2 user. An example of that alert is on the bottom of the page. These alerts could also be sent out to surrounding jurisdictions and it would allow first responders, public health, and public safety to mobilize a response strategy. North Carolina currently has Forsyth County EMS signed up. They just joined us last month in August. It is our first pilot location for overdose tracking using ODMAP. We are now working through deconflicting the incidents entered and still in the learning process with our pilot county, and we plan to report back future successes. So I gave an overview of the HIDTA program, our presence in North Carolina with the HIDTA heroin response strategy, and my role in facilitating data sharing with law enforcement, including monthly reports and piloting ODMAP. Other projects I'm currently involved in are mapping HIDTA drug seizure data with overdoses, conducting interviews with law enforcement leadership about their experiences with the Good Samaritan law, participating with county-based opioid action groups, collecting data from law enforcement overdose incident reports to evaluate circumstances involving overdoses, and supporting the Injury and Violence Prevention branch here at the division in updating their opioid surveillance definitions with the transition to ICD-10-CM coding. These are just to list a few. Thank you so much for your time and attention. Please feel free to contact me by these emails and phone number, and let me know if there are any questions.
So Sherani, it looks like you have a few questions.
Okay.
Here's the first one, and someone is asking, how do counties become designated as a HIDTA site?
I'm not completely sure how the HIDTA counties are selected. It does go through a process where an agency would submit a request to our HIDTA headquarter office in Atlanta, and I'm not completely sure, but I can connect you with the right person to identify how to become a HIDTA county.
Okay, here's a couple of other ones. So one of them says, which North Carolina counties are currently HIDTA sites? I think you had a slide for that.
Yeah, I have a slide of the 15 counties.
So there are the 15 counties in North Carolina that are currently part of that. And then the next question looks like is, can our area use ODMAP?
Yes. My drug intelligence colleague and I would be happy to assist a new county in becoming or implementing ODMAPs. I can do a presentation on that, but we currently only have Forsyth County as our pilot county and are still in the process of learning how this is going to work, but we'd be happy to set up a new county. It would be ideal, though, if it was EMS and the first responders who participate and are entering the incidents, though.
Yeah, so it looks like that kind of answers another question. The other one says, does it have to be an EMS public safety to join ODMAP? Will it ever be open to the public? Sounds like a good question.
Yeah, I think the level 2 user, the ones that see the incidents, should be the public safety, public health, and EMS officials and analysts, and they can decide once they receive spikes or high incidents, like how to disseminate that message to the public. But it does go through public safety and public health officials.
So it looks like one last question. Again, I'm not sure if you know the answer, but they could probably follow up with you more directly by emailing you. But this person asked, do you know if the Eastern Band of Cherokee Indians would be able to apply for that designation?
To become a HIDTA county or for ODMAP?
We don't know. Let's assume they're saying for the HIDTA. I'm assuming it was for HIDTA.
Possibly. I can put you in touch with the headquarter office to find out if that area can receive HIDTA resources for addressing drug trafficking.
Well, great. Well, that's perfect. So let me step back in and present the next piece of this. Again, this is Scott Proescholdbell, and I just wanted to provide a brief update on some overdose trends in general, and a little bit around the North Carolina Opioid Action Plan metrics. So here's the plan for today. Hopefully I'll just provide a brief national update on some data that's coming out. Again, a brief update on some North Carolina specific data, and then a look at the North Carolina Action Plan, specifically the data metrics that are being used, and a few things that we're hopefully going to be doing in the future. First, from the national landscape. New estimates by the CDC's National Center for Health Statistics from this month for 2016 have estimated more than 64,000 people dying from drug overdose. This includes all intents and includes over-the-counter, prescription-controlled, and illicit substances. This graph is from the New York Times, which also highlights peak numbers for other health crises, such as peak car crash fatalities, peak HIV/AIDS, and peak firearm mortalities throughout time. Looking more specifically at the drug type as identified by the ICD-10 mortality coding, heroin and other synthetic narcotics, typically fentanyl and its analogs, have increased dramatically in the last few years compared to the commonly prescribed opioids such as oxycodone and hydrocodone. Methadone used for pain control, not for treatment of addiction, has also decreased over time. Several states show significant increases from 2014 to 2015, including North Carolina. Hopefully that 2016 data will be finalized soon, and we'll be able to update this map and see if additional changes included North Carolina. So now, again, just a few North Carolina trends, and it's a particularly busy time because as we kind of close out some of this data, we go through a process where we really try to update a lot of these slides and make them available to people. So, we've been able to do that for a fair amount, but not everything. So here's a few that we have. This one has not been updated, but I still think it's an interesting data point, and we use this a lot in presentations. It's nearly 50 years of data for two very specific types of injuries. For the past century, motor vehicle deaths have been the leading cause of injury death, both in North Carolina and the U.S. In North Carolina, drug overdoses from all intents overtook motor vehicle crashes in 2010, like many other states, to become the leading cause of injury death for the state. And it's a combination of factors that help explain both the rise in overdose and the decline in motor vehicle. And, I think it tells two powerful stories about public health and society's at large ability to address significant health issues over time. Hopefully we'll act like we have with motor vehicle over the past, decades to really make sure that that is in decline and in order to help really turn the tide for drug overdose. So again, today, in North Carolina, more than 3 people die every day as a result of opioid overdose. and it continues to increase. In North Carolina, as the United States as a whole, deaths due to medication and drug overdoses have been steadily increasing since 1999. The vast majority, 85% plus, are unintentional. Last year, an average of 5 people a day died from medication and drug overdoses in North Carolina. Again, this is a slightly broader category than just opioids. That number of medication and drug deaths has increased 410%, from 363 in 1999 to over 1,851 in 2016. While the number of self-inflicted deaths or suicides have remained relatively stable, less than 200 a year, the unintentional drug overdoses have continued to rise. Opioids specifically have contributed to the majority of these deaths. The epidemic of medication and drug overdose is mostly driven by opiates, specifically prescription opioids. Historically, prescription opioids like hydrocodone, oxycodone, morphine have contributed to an increasing number of medication and drug overdose deaths. More recently, other synthetic narcotics and things like heroin, fentanyl, and fentanyl analogs are resulting in increasing deaths. The number of deaths involving cocaine are also on the rise. Keep in mind that these counts are not mutually exclusive. If a death involves multiple drugs, it can be counted in multiple lines. And one last note, fentanyl analogs are drugs that are similar to fentanyl, but have been chemically modified in order to bypass current drug laws. The rates of unintentional medication and drug overdose deaths rates from 2012 to 2016. Here we used a 5-year period to try to get stable numbers so that we could calculate some of the rates. Unintentional medication drug deaths cost approximately $2.1 billion in 2016 alone. This includes medical costs and work costs, but these figures do not include costs associated with treatment and recovery. Here is a graphic that depicts the increase in unintentional opioid deaths. Unintentional opioid deaths have increased from just over 100 in 1999 to over 1,300 in 2016. These numbers include deaths from both prescription and illicit opioids. The green portion of this graph shows the number of opioid deaths due to prescription opioids, specifically the T code 40.2, which is other opioids, and or T40.3, which is methadone. The dark blue portion shows the opioid deaths due to illicit opioids, or T40.1, which is a specific code for heroin, and T40.4, which is other synthetic narcotics. The light blue middle portion of the graph are deaths due to both prescription and illicit opioids. The prescription opioid deaths have been slightly decreasing, with the occasional small increase since 2008. Deaths due to prescription opioids seem to be leveling off, while deaths due to illicit opioids continue to increase and are accounting for a larger proportion of total opioid deaths. Keep in mind, it's still estimated that 80% of heroin users start with prescription opioids. The recent changes in mortality have also been partly related to access, cost, and potency of drugs. Here's a graphic, not to scale, that shows the various potency of drugs compared to morphine. A larger proportion of deaths investigated by the Office of the Chief Medical Examiner, or OCME, are testing positive for heroin, fentanyl, and fentanyl analogs. Fentanyl is a potent narcotic analgesic. The drug is available by prescription as indicated for cancer and chronic pain, but is additionally manufactured in illicit drug laboratories. Fentanyl analogs are drugs with the main structural features of fentanyl that have been modified to bypass current U.S. drug laws and or change the pharmacological profile of the drug. While the OCME Tox Lab had not detected any fentanyl analogs prior to 2014, fentanyl has been regularly detected in the decedent population since the mid-90s. By 2016, numerous fentanyl analogs were being detected and confirmed. Heroin is often supplemented with varying amounts of fentanyl or fentanyl analogs, which explains the increasing numbers of cases testing positive for both. And just a quick plug, our November data webinar will have Dr. Winokur from the toxicology at OCME present, and she'll be able to expand upon many of these situations and hopefully provide some additional and updated information. Emergency department or ED visits for opioid overdoses are increasing. Heroin overdose ED visits significantly increased since 2011, as shown in the blue. Many of these cases could also include fentanyl. The use of naloxone by emergency medical services has increased dramatically during this time, and this is the line shown in the graph. It's estimated that EMS uses naloxone around 40 times a day currently in the state of North Carolina. Both the percent of newborn infants going through drug withdrawal, mostly NAS, but not exclusively, and the increase in children entering foster care as a result of substance use has increased. Of course, the health outcomes are mere the tip of the pyramid. There are many behavioral and criminal justice issues that other groups are tracking and reporting. Public health, by and large, tends to focus on the health outcomes, the very two top layers historically. So now I wanted to switch gears a little bit and talk a little bit about North Carolina's response to date. Many agencies, organizations, and partners have come together as part of North Carolina's coordinated response as part of the Opioid and Prescription Drug Abuse Advisory Council, or OPDAC. OPDAC was created by statute and is currently being staffed by the Division of Public Health and the Division of Mental Health. The OPDAC group serves as the coordinating body for the state and has been officially meeting for just over a year. Prior to this official group, there were several smaller groups convening. OPDAC has a website that houses some of the background materials such as agendas and meeting dates, and we'll try to post that into the chat box to make it easier for folks to access. OPDAC was again created by the general statute and has several working groups under broad areas such as prevention, intervention, professional training, and core data. Again, this webinar series is part of the data team's activities. The North Carolina Opioid Action Plan was updated in the summer of 2017 and was a specific outcome from the OPDAC members and created to operationalize the statewide strategic plan and have greater accountability by lead agencies and organizations. Again, the full plan is available at the DHH website, which I believe is listed on the next slide. So again, broadly speaking, the Opioid Action Plan in North Carolina has several key strategic focus areas, including, coordinating or to create a coordinated infrastructure, and this can happen at the state level, and we're hoping it will happen at some of the local levels. Reduce the oversupply of prescription opioids. Reduce the diversion of prescription drugs and the flow of illicit drugs, increase community awareness and prevention, make naloxone widely available and link folks to overdose survivors to care, expand treatment and recovery, and of course, measuring our impact. So again, I'll talk a little bit about the measuring of the impact. Here are the data metrics that the state have developed to date to try and monitor changes in the epidemic. Each quarter of the year, the metrics will be updated where possible and used to measure impact. Many are still subject to change, but hopefully the majority will provide a quick overview of important outcomes, such as deaths, ED visits, and treatment. It's a very small slide on probably many of your devices, but it does provide around 16 different metrics, and it captures several different places where we're trying to measure what's going on. But again, if you want to see the slide in its totality and then some of the actual metrics that were current as of this summer, you can go to the DHHS opioid website, and the entire action plan is available there, including some of the metrics. So I also wanted to tell you a little bit about some things that are being worked on and hopefully will be coming soon. And again, I want to encourage you, if you have questions or concerns, to go ahead and either put them in the chat box or to put them in the Q&A box. Looks like we have a couple already. But in terms of things that are coming soon, the metrics that we hope to provide will hopefully be updated quarterly. There are some data systems that just doesn't make sense for, or that aren't able to provide it in kind of that pattern. But for the ones that have, we'll definitely create and update those. There are several kind of data warehouses and dashboards being developed at this time. North Carolina is fortunate that, again, NC Detect, for those who are authorized users, they have an existing set of dashboards that can be used for authorized users that both track emergency department visits related to a full range of overdoses, and then some of the EMS data as well, including naloxone administrations. The Division of Mental Health is working on a dashboard called NC Support, which has several opioid-specific measures by county. It also includes some other substance abuse topics, such as alcohol and other things, and many of which are also done by county. The CSRS, which is the Controlled Substance Reporting System, has a website that houses the CSRS data. It has both some of registration information and then information on the dispensing of controlled substances in our state. Again, much of that is also available by county. I think currently one of their pages has been taken offline for maintenance, but hopefully it will be back up soon. And then just to expand upon this, DHHS, the Department of Health and Human Services, is working on a comprehensive data dashboard that tracks all of the action plan metrics, including some potential process evaluation pieces and beyond that. The Division of Public Health also historically has updated at this time of year a series of data tables. We're in the process of updating some of those data tables now for deaths, hospital, and also emergency department visits. The challenge with both hospital and emergency department visits has been the United States has switched recently from the ICD-9 CM coding system to the ICD-10 coding system. And that change has resulted in a real challenge because it was halfway through a calendar year. And it's also a little unclear how the new coding system impacts overdose. At the broadest levels, it seems to match up fairly well, but at some of those more detailed levels, it's a little unclear if things are being better definitions are being used, or just different definitions are being used. And so it's going to be just, probably all of our tables will have something along this line, and probably many of our slides in the future for both hospital discharge and ED data will have some kind of break for 2015, and then data for 2016. But it's probably a little bit challenging to make comparisons between before 2015 and after 2015. Again, there's also, and you heard about this on the last data webinar, a series of special studies that have been coordinated through UNC, the Injury Prevention Research Center. They shared some information on the last webinar around one of the special populations we're working with, which are folks who are released from the prison system, so formerly incarcerated populations. They also shared some work around pharmacies, surveys, and works that they're doing. There's currently discussions around how to evaluate the STOP Act and several other initiatives that will help us better understand the problems we're facing today. And then lastly, the OPDAC core data activities, again, including some of the data warehouse and management, but also data governance and linkage of data systems to each other, because one of the ways that we can really maximize some of the data that we have in our state would be to combine it in unique ways to help us understand some of these problems. So I'm going to end there. I see a few questions posted already, and I'll try to start answering them. This last slide just has some of our information. I'm also listing Mary Beth Cox, who is an epidemiologist here at the Division of Public Health. She is the primary point of contact for and doing a lot of the work for some of the drug overdose data requests and things of that nature. Let me again jump over to some of the questions we're seeing, and again encourage folks to list some. I'm seeing 4 at the moment, so we'll try to put them together. The first one I'm seeing, when will the action plan metrics be updated, and how will they be available? Our goal is to get that information from each of the data sources on a quarterly basis and to post that quarterly. Currently, it's in more or less of a PowerPoint slide update. The newest update will hopefully be posted in the beginning of October, and that will be inclusive of the first 3 quarters of 2017. Next question that I'm seeing is, when you're talking about newborn withdrawal, what does the NAS stand for? Great question, sorry. We sometimes get into our alphabet soups. NAS refers to neonatal abstinence syndrome. It's a complex diagnosis that occurs among infants who are born to women who are addicted to opioids or who have opioids in their system and essentially pass that part of that addiction on to the infant. One of the data slides we have, I don't think in this presentation, but in others, tracks the drug infants who are born from a drug withdrawal, not all of which are NAS, but many of which are NAS. And that's really our best measure. It's kind of a proxy measure for what we have in our state around NAS. There are some states that have that as a reportable condition. It is a little complicated. Again, I'd be happy to talk with people who are interested in that offline. Good question, though. All right, next question. And it looks like we have a fair amount of time, so again, feel free to put questions in, but let me see if we can answer some of these others. Okay, another good one. Will county level data be available? Where it's available, we'll try to make it, or if we have access to it, we'll try to make it available. We're frequently a secondary user of much of this data, and we have data use agreements in place with lots of our data sources, many of which have stipulations around how we can use the data. And much of those stipulations really resolve around a couple of things, particularly for low numbers. If there's ever a potential to identify an individual, if there's 2 counts for a certain county, and there's been a lot of media attention, and maybe even the name has been mentioned in media accounts, even though it's kind of in the public domain on the media side, health sensitive information we usually suppress if the counts are less than 10. The other reason that sometimes some of those numbers are suppressed or withheld is sometimes the small numbers for mathematical purposes when we try to calculate rates and try to make comparisons between counties or between jurisdictions, those low numbers just aren't really stable. So if you have a switch from 5 to 10, that can certainly be a dramatic increase in a county, but for mathematical purposes, sometimes that might equate to a larger issue. But death data in our state is available for every county at the count level. For ED and health and hospital discharge data, generally numbers less than 10 are suppressed. Good question, though. How often, along the same lines, how often does data for counties get put together currently? Where can we access that? The Division of Public Health has a website under the Injury and Violence Prevention branch and the Data and Surveillance page that has many of these tables, the data tables that I was referring to in the past. We'll try to send out the website to some of those tables. We have tables for deaths, hospitals, and ED. We're hoping to expand upon that. We have several definitions, including the very broadest definitions, which mean poisonings, which include things well beyond opioids and even medication and drugs. Poisonings also include heavy metals, toxins, things of that nature. So that might not be important for the drug overdose group, but it's important for other purposes. That's the broadest category. It then kind of narrows down to very specific drug types, including heroin and other types. But because there can be polydrug use and people can have multiple drugs on board, again, some of those definitions can get a little bit challenging. So the next question I'm seeing, and the last question at the moment, is can we have access to the PowerPoint slides? Yep, these will be posted. We also have a core set of data slides that include talking points and technical notes. We're happy to send those out to jurisdictions and places. Again, we would recommend that you review and understand some of the data behind that, because there are some data caveats and some subtleties that are really important to understand particularly if you plan to present the information. Generally, we make it available as a PDF. If you're planning to use it as a PowerPoint slide, you can just contact me and we can discuss how that plans to be used. But we do plan to make that available. And then this presentation, which again is not the exact core data set I was just referring to, is being currently recorded, and once that gets processed and posted online, that will be available. Okay, so let me see if we're seeing anything else. Oh, there it is. It looks like Eva has posted the DHHS Injury and Violence Prevention Branch data surveillance website in the chat box area. So again, go ahead and cut and paste all of those onto another document somewhere so you guys have them for the future. Those are really good resources, and hopefully we'll continue to expand some of those. I'm not currently seeing any other questions, so let me make sure that, kind of last call. So either questions for Sherani about some of the HIDTA efforts and some of our collaborations with law enforcement and how we're trying to work on projects jointly to help us better understand, both the law enforcement part of the equation and also the public health part of the equation. Or if you have other questions or concerns about the slides that I presented on the action plan or some of the data metrics. We'll give folks a minute or two, and if we don't have additional questions, we'll end early. So if you have them, post them now. Otherwise, we'll end a little early and return a few extra minutes to your day. All right, well, it looks like we had a good number join us for today's call, somewhere in the area of 45 or so. So thank you all for joining us for today's webinar. Again, we're hosting these monthly. Let me just post this final slide. Yep, there's another question. Sorry, since we have the time, I'll answer it. So do you do local presentations? We do if we can. To be quite honest, we get so many requests at this point that they're really challenging for us to meet the need. But we can, if we can and we're available, we're happy to help present. We're happy to help present for folks, but we're also happy to share some of those slides so people can do that locally. It just depends. So feel free to contact us, and we have kind of a speakers bureau at this point, and it just all depends on the timing of things. With enough advance notice, generally it happens a little bit easier than if it's hey, this week we have a community coalition meeting and we'd love to have you come and present at 9 o'clock on a Friday night. So again, we can do those things, but as much lead time as possible probably enables us to do that a little bit easier. If we can't do the presentation, we're happy to provide some of the basic slides, and again, within enough advance notice, we can even try to provide local level, county level data for that area. So it looks like we don't have any other questions, so let me wrap up some of today's the webinar. Again, I want to thank you all for attending the third data webinar in the series around tracking and measuring the opioid epidemic as a prevention tool. I want to remind you that this webinar has been recorded and will be made available to you. Again, you can check the website for past webinars as they'll be posted there. I hope you'll join us next month on October 19th, the third Thursday from noon to 1. The October webinar will feature the state epidemiologist Zach Moore from the North Carolina Division of Public Health Epidemiology section, and Anna Delaney from the Carolinas Poison Control Center. They'll both split part of that time and provide presentations, and people can ask questions about the work that they're doing related to the opioid epidemic. On November 16th, as I mentioned earlier, Dr. Ruth Winokur from the North Carolina Office of the Chief Medical Examiner will present, and so we're looking forward to that. Currently, we don't have a December presentation planned. We're happy to provide a presentation. Sometimes December can be a challenging month for that. So at the moment, we don't have anything posted, but give us your feedback if you want to hear more about the things that are happening on in this area. We're happy to try to identify people to present. And then that goes into 2018 as well. If people are finding these useful and helpful, we're happy to expand and contribute those. Again, I would just point out that these presentations, more information about these presentations or future webinars, you can go and visit the webinar opioid that Eva posted earlier. Thank you all for being here today and for all the work you do to prevent overdoses in North Carolina. And we'll sign off now. Thank you very much.